You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from benchside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by MiKaela Olsen, Clinical Nurse Specialist in the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Hospital and Greenspring Oncology in Baltimore, Maryland. MiKaela is the lead editor of the ONS Chemotherapy, Immunotherapy Guidelines and Recommendations for Practice, and is here with us today to discuss extravasation of antineoplastic agents used in cancer care. Thanks for joining me today, MiKaela.
Thank you for having me.
So we're just going to start off with kind of the basics and fundamentals of this today. So can you tell me what an extravasation is?
So an extravasation is kind of a broad term describing the leakage or infiltration of intravenous drugs or fluids into the extravascular tissue. When the leakage of a particular drug does not have the potential to cause serious injury, such as a tissue necrosis, we usually use the term infiltration. For drugs classified as vesicants, those drugs that can cause tissue damage, such as blistering and necrosis, we use the term vesicant extravasation. So that just kind of narrows it down a little bit. It is kind of a broad term.
So in oncology care and cancer care, we don't only use chemotherapy, but we use other types of drugs as well. Can you tell us which drugs are at risk for causing an extravasation?
There are quite a large number of chemotherapy drugs that are considered vesicants, such as anthracycline agents like doxorubicin and epirubicin. We have the vinca alkaloids, such as vincristine and vinorelbine. Trabectedin is considered a vesicant, and nitrogen mustard. Those are just to name a few. We've learned how to maximally dilute certain chemotherapy drugs, which minimize their risk of tissue damage and allow us to refer to them as irritants or mild vesicants. Cisplatin and the taxanes are drugs that used to be considered much more serious vesicants, but over time we've learned how to give those in a safer manner using proper dilution when compounding. There are also a number of non-chemotherapy drugs that are vesicants. The ones that we deal with a lot in my institution that we give commonly include things like contrast media, things like Phenergan, calcium chloride, calcium gluconate, amiodarone. So those are just a few. There's actually a pretty large list of non-chemotherapy vesicants that you have to consider when you're administering medications. So having a policy and procedure in place is really important.
Okay, good. When you were explaining to us what an extravasation is, you mentioned vesicants and irritants. Can you tell us what the difference between those two are?
Well, an irritant is something that when it is infused into the vein can cause some local reactions such as burning or pain, achiness in the arm or the area where it's being given. It's a substance, a drug that can really cause irritation to the vein. And some vesicants are actually irritants as well. So that can make it tricky when you're administering these drugs. Irritants can also cause redness and inflammation and discoloration, but they typically, if they extravasate, they don't tend to cause tissue necrosis. A vesicant causes blistering and or tissue necrosis that can be devastating and may require surgical grafting.
That was a very good explanation of the two of them. And another thing that I heard you say earlier also was with some of these drugs that you were mentioning would be at a risk for having an extravasation when they're administered. You mentioned the maximum dilution. So if there are ways to dilute these drugs to help from preventing an extravasation, I hear you saying that's one way. Are there other ways that we can help to prevent that from happening with our patients?
Absolutely. So I always bring it back to the patient to start with. So every patient should have a thorough review of their history. We should understand what has their vascular access history been? How many lines have they had? What types of lines have they had? What kind of medications have they had infused through their veins? Because we know that medications can cause sclerosis of the vein, hardening of the vein, and other types of damage, irritation, etc. So we really need to understand, what has this patient gotten? Have there been any previous issues with vascular access device? Have they had difficult or multiple VAD insertions, infiltrations? Have they ever had a vesicant extravasation? Have they had a history of thrombus, sclerosis I mentioned? So really understanding the patient's vein health. And then what is the planned regimen? There are some regimens that we know need a central line for administration, such as those where we're going to give a continuous vesicant. So it's important to know that. It's important to have that written into your treatment plans so that the patient doesn't show up for a regimen that requires a central line and that hasn't been put in yet. Many of our regimens we can give peripherally, but we just have to be smart about it. We have to be able to know that patient's history and assess their vein health. Other things that I use, tools that I use ultrasound technology sometimes to look at someone's peripheral vein health. An ultrasound, if you're properly trained in using it, can help you see not only whether veins are sclerosed or have good free flowing blood in them, but also is there thrombus? There's sometimes thrombus that's accumulated in the periphery because of multiple sticks. Are the veins damaged in any way? And that's really important to know when we're going to be putting IVs in these patients. There also is infrared technology that can help you look at whether the vein fills when you put pressure on the valve and whether the veins look healthy to you. So there is technology. If that's not available, then using good regular palpation, making sure the vein feels soft before you access it, and just ensuring that you've got a good access. And if you're unsure, or if you have someone that can only use one arm for their vascular access devices and you're already concerned about the lack of veins, then somebody with more skill or an interventional radiologist might have to look at that patient to see what other options there are. And I also always talk to the patient, have a discussion with them. They often know their body. Well, they do know their body better than anyone else, and they often have important information that can guide us. And then next, some general principles for preventing extravasation. I like to go by the ONS recommendations in the guidelines that talk about the use of the forearm, not the wrist, avoiding the hand or the antecubital area, start distal and move proximal, avoid any areas below a recent venipuncture site. And the recommendation is to not go below a recent venipuncture site for at least 24 hours after, so that site can heal. And then to use and choose straight veins, use a skilled inserter that can access that vein without causing a lot of trauma in the area that can later lead to an infiltration or an extravasation. And then ultrasound technology, as I spoke about before, that's a newer technique that's being used more frequently across the United States, but also can have issues if people are not really trained and skilled in how to use it. But it can be a really great tool when used properly. Also, I always focus people on making sure we challenge the vascular access device with normal saline prior to administering the vesicant. You want to make sure that it's properly functioning and has a good blood return before you start. And then, of course, another strategy to prevent extravasation and minimize the harm if you do have an extravasation is to check a blood return every 2 to 5 cc's during administration. So if you are giving a peripheral vesicant and you are constantly diluting it at the same time and then stopping every 2 to 5 cc's to check a blood return, you're going to catch an extravasation very early on when a very minimal amount of vesicant has extravasated. And then I have quite a few tips here for central lines. Always ensure that there's a vigorous blood return. Really, a lack of blood return in a central line could mean that there's a fibrin sheath, which could result in a retrograde flow of vesicant, which also could result in an extravasation at the central venous axis insertion site. And I've seen some pretty terrible cases of retrograde flow from those fibrin sheaths. The central venous catheter could be damaged. It could be malpositioned. It could have a puncture or a hole in it. Sometimes you can see a port body become disconnected from the actual port tubing. And I've seen that as recently as a couple of months ago. So even some of our newer ports, this could happen to the patient. So always listen to the patient, any complaints of coldness or pressure or burning or anything, and always make sure that you challenge these catheters, whether they're peripheral or central, with a good amount of IV push saline to make sure you feel really good about the line and it has a vigorous blood return. Central lines that don't have a blood return, it's really important to prevent extravasation that we do not use those for chemotherapy, especially vesicant chemotherapy. They may need to have a dye study to determine functionality prior to use. And really, I teach people all the time that a central line that has a persistent lack of blood return needs to be evaluated and revised. We shouldn't have something in the body that's meant to be used to give therapy and to draw blood that only works halfway. And for many reasons, we don't want to ever give chemotherapy through a line without a blood return. In addition to extravasation, we can cause other harm by doing that. So it's really important that our lines always have a good blood return. Other tips for preventing extravasation: never administer peripheral vesicants through an infusion pump. And that's also one of the ONS chemotherapy and immunotherapy guideline recommendations. We want to make sure that peripheral vesicants are always given via gravity through a free-flowing primary IV line. And again, you're diluting the vesicant so that, and you're checking a frequent blood return so that if you do extravasate, you have dilute drug going in and you catch it very early. You want to also remain with the patient during the peripheral vesicant administration and make sure there's a transparent dressing over the site so that you can visualize the site at all times and notice if anything goes awry. And you want to limit any peripheral vesicant administration to less than or equal to 30 minutes. We talked a little bit earlier about making sure you verify the blood return every 2 to 5 cc's for that IV push. And if you're giving a short-term gravity mini bag vesicant infusion, then you need to check your blood return every 5 minutes during that time. So use lots of dilution, check a blood return frequently, and most importantly, listen to the patient. Hand off your other patients so that you can give your full attention to this activity. I see a lot of people distracted and worrying about their other patients, and an easy thing to do is just make sure you hand off everybody so you can really give that patient your full attention. So that was a lot, but it's a comprehensive topic and it requires a lot of prevention.
That was a lot. You're right. Are many of those recommendations that you just mentioned included in the chemotherapy and immunotherapy guidelines and recommendations?
Yes, they all are included in there. It's very detailed. And we wrote the book in sections. In the administration section, you can actually find how to give an IV push vesicant, how to give a mini bag vesicant, how to give a non-vesicant. And it's really, really detailed with all the steps and these exact recommendations.
That's good to know. I think, these kind of medications make nurses nervous when they're giving them for good reason because of what can happen with them, but to be able to have a reference to go back to and just make sure, especially if you haven't administered one in a while or you're new and you want to look at what your institution's policies are as well as what the guidelines and recommendations have to say.
Right, exactly.
So let's say that you are administering this and you have a patient who experiences an extravasation. How is that managed when that happens?
Well, I would say most importantly, again, listen to your patient. And if they complain of anything at all, you should consider it real and you should investigate thoroughly. You should stop what you're doing. Before you start giving the vesicant, it's really important to tell your patient what you're doing and what you're giving and what the risk is and what you're doing to protect their vein and protect them from an extravasation. I've seen quite a few times where people don't tell the patient what's going to happen because they don't want to scare them. And that's really not appropriate. We have to make sure our patients receive informed consent, verbal or written. And everything I'm saying really doesn't matter if you're giving it in a peripheral vein or a central vein. We know that extravasations can happen in any kind of a vascular access device. So we follow our institutional policies, inform the patient, let them know what symptoms and problems that you want them to quickly inform you of while you're administering it. And then get comfortable next to the patient when you're giving the vesicant, whether it's in a central line or a peripheral line, and then begin to dilute the drug and give it carefully. If it extravasates, or if you have any signs and symptoms that it might have extravasated, or any complaints from the patient of burning, tightness, warmth, cold, pressure, then listen and stop the infusion. You may check a blood return and you may still see a blood return, but the patient may be complaining of some of these symptoms. So even in the presence of a blood return, if we have other indications that we may have an extravasation, we need to stop. And then we would immediately assess the blood return and the site. We would ensure that we have that transparent dressing over that site so we can observe and see if there's any leakage at the site. And then the key interventions would be to stop, to immediately aspirate. And the reason to aspirate is you're trying to pull out any remaining vesicant that may be in the needle or in the tissue around the needle that you can aspirate out. So you want to use a really small syringe if possible to try to aspirate any of that vesicant out of there. The next thing on the list to do after you've aspirated and stopped everything is to look at the vesicant extravasation guidelines. So some of the vesicants require warm and some require cold as an antidote. And then there may be a medication antidote that's indicated. And then after figuring out if we're going to be giving a medication antidote, then good documentation of the event and good patient follow-up is really key.
So you mentioned antidotes, possibly medication antidote, because you also mentioned either warm or cold. Is that something that the administering nurse can just go ahead and apply or administer, or does that have to be done by a physician or an APP in this situation?
Yeah, I think nurses typically do administer the antidotes. A few of the antidotes are given intradermal around the extravasation site or within the extravasation site. Some antidotes are given IV, and that really depends upon the specific medication that extravasated and its evidence-based intervention. But nurses absolutely should quickly apply the warm or cold and then figure out if there is a medicine antidote and then work on getting an order for that.
Would you recommend that if you know you're administering a treatment that could potentially cause extravasation, be a vesicant, that there would be a standing order for an antidote in the event that you would have something like this happen?
Yeah, I think that any of these kinds of infusion reactions or problems like vesicant extravasations or hypersensitivity reactions, we always do better when we have everything prepared and we're ready to go and we understand how to respond in the event that there's one of these occurrences. And I think standing orders can help expedite the treatment of an actual or suspected vesicant extravasation. In fact, the ONS and ASCO guidelines require that extravasation management procedures are defined and align with the current literature and guidelines. So antidote order sets and antidotes should also be accessible per the ONS ASCO guidelines standards, within the appropriate time frame. So that's a requirement of those standards. So it also helps when I go to smaller community practices, I talk to them about these standards and how we really need to be prepared at those sites. They may not even have the antidotes on site in the smaller community practice. So they need to have a policy in place for how to quickly get these antidotes into their facility to be able to treat the patient. An important consideration also is if you don't have the antidotes on site because of expiration or other practices other reasons that the practice has identified, then having a plan for how you can courier those antidotes over very quickly, getting them to the patient in the recommended time frame. For instance, if you extravasate an anthracycline such as doxorubicin, it's recommended that you give dexamethasone within 6 hours from the time of extravasation. So the practice needs a plan for how to be able to do that. And then for that particular antidote, you have to give the patient subsequent days the dose on day 2 and 3, and you have to give it around the same time as you gave it on day 1. So what if it's a Friday in a small community practice and they're not open on the weekend? There needs to be a written plan in place for how that patient's going to go to a larger facility on the weekend to be able to get their antidote to minimize the risk of severe extravasation. And the order sets can be very helpful because they can include not only the vesicants and the administration routes and the specific directions for administration, but they can also include aspects of monitoring and follow-up for the patient post-extravasation.
It's a lot to remember. So you mentioned when I asked about, what would need to happen if extravasation occurred, and that the nurse would need to look at the policy for extravasation that their institution or their practice, their outpatient practice has. Can you tell us, are there a list of specific things that should be included in that policy, or what really should definitely be in there if someone does not have one and they'd like to get one started?
So I would start by looking at the infusion-related complication chapter in the ONS chemotherapy guidelines. It gives a lot of guidance about the specific vesicants and irritants and some of the information about the evidence-based interventions and prevention. And that should be the guide for writing the policy. But an extravasation policy should include a list of vesicants, of course, and even irritants, because some are both, and the evidence-based management interventions to guide the staff. And the policy should include the details for administering the interventions, such as, it seems silly, but there actually should be a cold procedure. How do you apply the cold? What is the best type of cold? How long does it stay on? How frequently do you administer the cold? And the same with warm. And then that way, the nurse is also clear on how to instruct the patient to do that when they go home. Same thing with the intradermal administration and the IV administration. The policy should also include patient monitoring and the follow-up plan, documentation requirements, and the procedure for referring patients when necessary to plastic surgery. So in my organization, we have a pretty large vesicant and irritant policy, and it's really, really helpful. It has appendices with tables so that the nurse can quickly look up the drug alphabetically and then quickly reference what the treatment would be if that drug extravasated. And so those are the most important things I think should be included in an extravasation policy.
Is there such a thing as an extravasation kit that they could have ready to go, or that, they have available when they're administering these type of therapies?
If the practice chooses to have a specific kit for extravasation, it should include supplies to initiate cold and warm topical treatment. It could include medications that are evidence-based for the treatment of vesicant extravasations. However, some institutions tend to keep the medicine antidotes in the pharmacy because the good news is, at least my organization and many others, we see very few vesicant extravasations now. And I think that's in part due to the great nursing education and teaching and the ONS chemotherapy guidelines that really help us understand the practice of administering these drugs. And so as they've become less, our drugs will expire more frequently. And so having multiple kits around the hospital or in the infusion clinic can be wasteful at times. So some people I know still do try to do the kit thing. Some of the antidotes, like the ones that have to be drawn up in syringes, or the ones that are drawn up and compounded in an IV formulation, have to be done in the pharmacy fairly close to the time of administration. So it's not something we can keep in a kit necessarily. And we have had shortages of our antidotes, which is also, at least in my pharmacy, made them less willing to put them in a kit because they want to preserve them and keep them in the pharmacy. And that's fine as long as the pharmacy has the ability to quickly dispense those antidotes so that they are given in the recommended timeline and that we don't have delays. So working with your pharmacy colleagues on the policy and the interventions is really key.
Okay, thank you. I'd like to ask you a couple of questions. We frequently get questions from the ONS member community, so I have a few that I wanted to ask you about. The first one being related to vinca alkaloid administration. And many centers have policies against infusing vesicants IV piggyback, but they want to transition that treatment to an IV piggyback setup. Do you have any suggestions on how they could proceed with making that kind of change?
Sure. And as a little bit of background, it's really, really important that we all stop giving vinca alkaloids via syringes. This is also an ONS ASCO standard, and the standard says that the healthcare setting that administers intrathecal chemotherapy should have a policy in place that specifies that intravenous vinca alkaloids are administered only by infusion, for example, mini bags. And over 150 people have died worldwide from accidental administration of the vinca alkaloids via the intrathecal route. And many of these patients were receiving potentially curative therapy for their cancer. And these deaths are completely avoidable. So by putting these drugs in a mini bag instead of a syringe, we greatly minimize the risk that the vinca alkaloid will be given into the cerebral spinal fluid, and we can save lives. And we need to use evidence to guide this decision. I remember when this first came out years ago, it was hard for me to think about giving these drugs in any other way but a syringe, because I felt I would lose control of that careful procedure that I had developed over the years with my constant dilution and my blood return checks at the closest port to the patient. But you can do that with a mini bag, and you can do it safely and effectively. And I know a few years ago, I had a poster at ONS around how to do this safely. And there was a poster a couple down from me that had from a neighboring institution that had a similar poster and similar results. So it can be done and it can be safe. I think a very important thing to know is that the risk of extravasation using a mini bag approach has been published to be less than 0.5% when administering these vinca alkaloids in that mini bag with dilution. So it is a safe thing to do, and it should be the standard of care everywhere.
And I have a couple of other ones that have come up also. Some of them you touched on earlier, and so I'm going to repeat it, and you can just give me a quick answer to them because you did touch on it. So when you're talking about the change to IV piggyback with the vincas, there have been members who have posted questions related to other vesicants being administered by that route as well. Do you have any suggestions for that?
I think vesicants definitely can safely be administered through peripheral IVs with the use of lots of safety checks that I mentioned earlier. Frequent blood return checks and dilution are key. Not everybody needs to get a central line. Central lines are not without risk. We know that central line associated bloodstream infections are the number one most common healthcare associated infection in the United States, has one of the highest mortalities, and definitely very, very costly, with one CLABSI being as much as a $40,000 cost to the organization and obviously lots of increased harm to the patient. And then we know that CLABSIs can cause thrombus. Central lines can cause thrombus. And we know that central lines are not necessary for everybody. Going back to the beginning, though, upfront assessments are key and include the patient in the decision-making and risk-benefit discussion. And that's why, as oncology nurses, we play a key role here and often advocate to the providers for what's best for individual patients. So I never advocate for one line or the other unless the regimen specifically requires such, but I really try to make sure that we do what's right for the patient.
Okay. Can you use a pump to infuse a vesicant IV piggyback?
Infusion pumps shouldn't be used to administer vesicant chemo through a peripheral vein ever. This should only be done with gravity. You can administer short-term and continuous infusion vesicants through a central line with an infusion pump. If the central line has a good blood return and the tip is in a central location, then that would be acceptable to do that on a pump. So those are sort of the guiding principles, and they are in the ONS chemotherapy guidelines.
One last question from the communities, and then we have a few other things before we finish up. How frequently should blood return be tested if the line peripheral versus central? Is there a difference in how frequently that should be done?
Yeah, so the ONS guidelines say that we should check a blood return prior to the start, challenge that vein really well with lots of saline flushes, and then check a blood return if you're giving it peripherally every 2 to 5 cc's for an IV push, every 5 minutes during a gravity mini bag infusion, such as the vinca alkaloids. And for checking a blood return in someone receiving a continuous infusion of a vesicant, we specifically say that that is done per your institutional guidelines. And obviously, if the pump alarms, if there's any signs and symptoms of extravasation, the blood return should be checked immediately and the vesicant should be stopped. Some institutions have a policy that says every 4 hours. Some do every shift. We specifically left that up to your institutional guidelines. And just remember that it's very important to flush vigorously after you draw blood back into that central line to prevent medication buildup and subsequent occlusions.
Okay, thank you. We've talked a lot about different methods of administration, pump versus a mini bag or IV push. Is there an increased risk by using one of those methods of administrations versus another?
Well, yes. The use of an infusion pump, as we said before, with peripheral vesicants should never be done. And because this definitely greatly increases the risk, as the pump may not detect an occlusion and the administration would continue into the tissue. There is also a risk of extravasation when you give vesicants via any route, whether it's peripheral or central. So careful administration through a fully functional venous access device is really key, and verification of the proper blood flow and diligent monitoring are really essential for prevention.
Okay. So we've talked about a lot, and we've talked a lot about just what the nurse needs to know to be able to manage these types of situations. And you've talked a lot about policies and different methods of administration and things like that. How can nurses be educated to be able to understand and administer and manage potential extravasations?
Oncology nurses should have a didactic foundation of knowledge. They should attend the chemotherapy and immunotherapy certificate course to receive education on vesicant administration and the management of extravasations. They should use those ONS chemotherapy, immunotherapy guidelines and recommendations for practice. And I mentioned earlier that detailed chapter called Administration Considerations can be used as a guide. The office practice or the institution should have a vesicant administration and management competency checklist for the actual skill checkoff. A lot of nurses will say to me, I'm chemo certified, and they don't understand that by taking the ONS chemotherapy certificate course, that's not certifying you. The only certification is the oncology certified nurse exam that you can take. But the practice of administering chemo has to be checked off at the institutional level by using a skills checklist and with a preceptor to be able to validate competency.
Thank you. Those are all really important things that I think nurses do need to know, and they need to have the access to that where they are and when they're administering those types of treatments. So what's something about extravasation that's not often discussed, but you wish people knew more about?
this is a good question, but it was a little bit tricky question. I think it's important to know that many drugs have vesicant potential, and through proper compounding and dilution and careful administration, we can really eliminate or minimize any risk. Examples include the cisplatin and taxanes, which are considered exfoliants. They cause inflammation, hyperpigmentation, and peeling of the skin. But we have learned over time to dilute them well to minimize exposure and risk. And the literature, this is an important thing that we changed in the latest guidelines based on supporting literature. We do allow the taxanes to be given peripherally over greater than 30 minutes, even though they have vesicant-like potential. And we still need to be super vigilant during administration and to avoid extravasation. So I would just say to keep in mind that change we made in the guidelines and know a little bit more about some of your drugs like the taxanes and the platinums that used to, back when I was a new nurse in the 80s, we used to treat them just like we did all the other vesicants. But there's some differences now based on the different ways we compound them.
And we talked about the education and how nurses can get that information. Are there any other resources for nurses wanting to learn more about vesicants and extravasations that you could recommend?
I definitely talked a lot about the Oncology Nursing Society recommendations. And I also myself refer to some of the Infusion Nursing Society standards that are out there. We have the ONS VAD standards that are available as well. So we have quite a number of resources.
Thank you. And I just want to thank you for being with us today. This is such an important topic, and there's so much to know and understand about all of this. It's also really a good thing to hear, like you said earlier, that the number of cases are definitely down from what they were years ago. But do you have any final thoughts or any final things that you'd like to share with us that we haven't already discussed?
Well, I think repetition is always good. And I think my final thoughts would just be to remember to challenge your vascular access device, no matter what kind it is, central versus peripherally, with plenty of IV push saline prior to administering these drugs. Ensure that you have excellent flow. These lines were meant to have good flow, and they should. Make sure that you have a good blood return. And I always say that if you extravasate during the saline challenge, then you prevented a much more serious problem. So take that time to do that. And then finally, always listen to your patient, listen to your gut, and when in doubt, stop, aspirate, and call for help. And I think that would be what I would like to leave everybody with.
Thank you so much. I really appreciate you being with us today and enjoyed our conversation.
Thank you for having me.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.